Hello, thank you for joining us. We'll get started in just a few minutes. Hello, and thank you for joining today's webinar. We are ready to begin. Today's webinar is eligible for one contact hour. Sigma Theta Tau International Honor Society of Nursing is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Centers Commission on Accreditation. The planning committee members and speaker have disclosed no relevant financial relationships. To receive contact hours for this NCPD session, participants are required to attend the webinar and log into our learning management system to complete an evaluation form. Information on how to access this will be emailed to all attendees approximately 1 week after the webinar. This webinar is being recorded and will be available on the Sigma repository within a few business days of recording. Following the presentation, if we have time, we will have a question and answer session. You'll see on your Zoom webinar control panel that you can send a question through the Q&A feature. This is where you can type in any question you'd like to pose to the presenter. Be sure to hit send so the message makes it to us. Please use the Q&A for questions and the chat feature to interact with other participants. We would like to thank our speaker today for sharing her expertise with us. Our speaker today is Cora O'Leary. Cora qualified in 2003 from the University of Brighton as children's nurse and worked in cardiology, emergency, ICU, retrievals, and humanitarian medical missions both nationally and internationally. Since 2012, Cora has been working with children with complex healthcare needs in the community. She has been working with resilience since 2014 and completed her MSc in 2018, which led to the inception of her current role as clinical practice specialist. We're so grateful to have you, Cora, and we'll turn it over to you.
Thank you, Linda. Hey everyone, thank you all for joining me today for this 1 hour webinar. And the name of the session is Realising Potential, from where you are today to where you can be. So as Linda said, my name is Cora O'Leary, and for the next hour, I'm going to explain to you how my career progressed into the current bespoke role that I have, which is a clinical practice specialist. My hope is for you guys, from learning where I've come from, that you will be able to identify at least one way to recognize opportunities that can benefit you and the patients you work with. And I want you to reflect and generate thoughts related to your individual career progression and divergence. Next slide, please, Catherine. First off, even though Linda gave you a very brief snapshot, I just want to go a little bit more in depth into my background and where I came from. So as Linda said, I'm a pediatric nurse. I trained and qualified in the UK, and the UK is one of the few countries that actually offer pediatric nursing as a standalone undergraduate course. So I qualified in 2003 with a diploma. And I always tend to say I qualified rather than graduated. And the reason for this is that when I actually qualified, I had done the apprenticeship style in nursing. So my training was predominantly based in the hospital setting. I only attended university on average 10 to 14 weeks a year. In 2009, both the UK and Ireland did obviously decide then, along with internationally, that all student nurses would commence a 4-year degree in nursing, which would primarily be based in universities. What I will say about my training is that I absolutely loved it. And I think for that part of the reason, I loved it because I was able to come back to the same ward every single year. So my mentors and preceptors could see my growth year on year. Once I qualified in 2003, I moved to London for 6 months and I worked in cardiology. From there, like most of us, I decided it was time to come home. So I moved home to Ireland and I worked in one of the tertiary paediatric centres over the next 5 years. And my career there included infant cardiology, cardiac ICU and emergency. During my time in A&E, randomly, a preterm baby was actually born down the toilet at home next door to the hospital, and he came into us, a little 27-week gestation baby. And I realised I wanted neonatal ICU experience. So from that, I actually moved to Cork in South Ireland, where a new maternity hospital had just opened. So in the hospital was a 50-bedded neonatal unit. It's the biggest in Ireland, with 12 cots in the ICU, 8 in the HDU, and 30 in the special care. Also during this time, I think, you know, for a lot of countries, it was the height of the boom. So I absolutely caught the travel bug. So I took time off ad hocly whenever I could to see the world. And I've been lucky enough to take a cargo boat down the Amazon. I've island hopped around Thailand and I've skydived in Australia. After my year in the neonates, then I headed off for Australia for a couple of years. So again, work experience abroad, like I'm sure many of you have undertaken. And there I worked in emergency again, and I was actually a coordinator with Retrieval Services Queensland. Many of you might know it as the Royal Flying Doctor Service. It was obviously a great few years and I loved it, but despite my love for travel and working abroad, home was calling and I moved closer to home, not quite home to Ireland, but I moved back to the UK, where I took on a role as a nurse manager in a general peds unit. I was there for 2 years at the time, and I actually undertook a course. It was a 4-month university course. I'm not too sure if many of you have heard of it. It's called the Mentorship and Preparation course, and it's all about teaching and learning student nurses and spending time with them. So essentially in the UK, when a student nurse is on their final placement, they have to have someone known as a sign-off mentor actually sign them off on their final module. So this 4-month course was my way of completing it and being a sign-off mentor. So essentially what that meant, at the end of a student nurse's either 3-year diploma or their 4-year degree, I was signing off to say that I felt confident that student nurse could work beside me on the ward as a qualified nurse. And it was actually linked with my nurse registration at the time in the UK. So it was quite an exact thing. It was also during this time, I suppose, that as Linda alluded to earlier, that I started my humanitarian aid work, and I actually completed my first 2 trips during my time as a manager in the UK. It was very much during that mentorship course that I recognised that I loved a few different things that I hadn't realised that I would like. So number 1, academia, and number 2, teaching and training, and teaching student nurses, you know, new skills and I suppose new pathways and new policies and guidance, and skills that they could manage and master. So from that, really, I had to make a decision. I knew I wanted to do my top-up degree in nursing, and I could either stay in the UK to do it, but it would actually take me about 3 to 4 years, because you can only do 1 to 2 modules per year is generally what you do. And then the modules are worth varying credits. And obviously then over 3 to 4 years, you'll get your full credits to give you your top-up degree. And this is what I did. I returned to Ireland in February 2012, and I started to do agency nursing in the community for kids with complex care needs. And I commenced my degree in September 2012 in the University College of Cork, because I could do it in 1 year. So from a financial, and let's be fair, even though I knew I liked academia, I wasn't sure I wanted to face into 4 years of doing it. Doing it in 1 year was just a little bit easier. From there, then I did fall in love with academia completely. One module that I did for my top-up degree was safeguarding vulnerable adults, and with the guidance of my lecturer, I actually commenced a postgrad diploma in child protection and welfare in Trinity. It was an unusual course, especially for nurses to do, because it was run through the School of Social Work and Policy, and it was a multidisciplinary team course. So there were social workers, there was police, there was doctors, there were solicitors, there was education welfare officers. So it was amazing to see how many people were involved in child protection and welfare, and to see everyone's different strand and role in it. From there, in 2014, when I finished up with that course, I was actually offered the role of team lead in resilience in the south of Ireland. And within a very short time frame, I became a nurse manager. I completed my master's in UCC. I'll come back to that in a little while. And following the outcome of my master's, that what was created for me and why we're here today is to talk about this bespoke role that was created for me. I've been at it since 2018, and it's currently the only one in Ireland. To further support part of my role, I completed another postgraduate course in Trinity College Dublin called Clinical Health Science Education. And again, Ireland is one of the only countries that offers it. It gave me a second registration. So I'm also a nurse tutor, a clinical nurse tutor as well. My humanitarian work definitely has not stopped either. And since 2010, I've completed 16 trips internationally. And most recently, in the last 3 months, I've returned from Iraq and the United Arab Emirates. Next slide, please. So in terms of complex healthcare needs, what exactly am I talking about? So every country does have a slightly different term. Okay, so I suppose I'll start there first off. And everyone's population of complex healthcare needs is slightly different. So in Ireland, it is an overarching term used for children and young people with nursing needs that are cared for in their own family home. Within this category are 3 smaller subcategories. There are children with life-limiting conditions such as spinal muscular atrophy, life-threatening conditions such as organ failure, so maybe somebody who's waiting for a lung transplant or a heart transplant, children who are palliative or end of life, and children dependent on medical technology, such as those with tracheostomies or ventilators. The overarching definition in Ireland is a child is defined as someone who has a range of conditions from complex care needs to life-limiting conditions. They will have functional limitations. They will often require technology assistance and ongoing nursing care. And the primary role is to support their parents to care from them at home. And the aim is always to prevent hospital readmissions and to avert death, or for a small few, provide palliative care. In Ireland in 2014, a big scoping exercise was done, and there were a few things that were looked into. The first off was, what was the primary diagnosis of children receiving nursing care in their own home? What parts of Ireland were they in? What were their nursing care needs? And most importantly, who was providing the care? And those providing the care, what were their policies? What were their guidelines? What was their governance structure? What the report highlighted hugely was the inequity of service provision and home care nursing hours. One of the big things that were realised was that there was a big gap between the nursing hours that a family were given and the nursing hours they were actually receiving. So they may be allocated 100 hours a week, but they might have only been getting 30 hours a week due to staffing issues and staff not being trained. A few things, other inequities were noticed as well, were those who shouted the loudest got the most. If a child didn't live in the city, the services were poorer. And one of the big things that was most worrying was the lack of governance and clinical structure surrounding this medically vulnerable group of children and young people. Ireland very much had an agency model for these children, which meant for some family there was no continuity of care. And as I've said previously, services were ad hoc. Following that report in 2017, the Republic of Ireland commenced what we now know as the Framework for Children with Complex Healthcare Needs. And what it's meant is that children requiring home care hours and services in their family home were now fully commissioned, contracted, managed by a provider with competent, confident nurses. This changed the agency model from approximately 20 agencies, charities, part-time funded charities, to 5 approved providers that have to attain and maintain a certain level of governance and quality of care to continue providing home care nursing hours. Next slide, please. It was in 2016 that I commenced my master's, and what I really wanted to look at was the nurses' knowledge and challenges for caring for children with complex healthcare needs in the communities. And particularly, I wanted to look at children who are technology dependent. At the time when I done my master's, when I was looking for any information on technology dependence, it all led back to this 1987 document from the Office of Technology Assistance in the US, actually, where I'm not too sure if many of you know, a young girl called Katie Beckett actually was discharged home with a tracheostomy and a ventilator. And it was actually the president, Ronald Reagan, that had to sign her discharge paperwork. Now, that's not that long ago. Okay, that's only 35-ish years ago. So we've come a huge way since then that these children are now able to go home. The objective of my master's was to explore nurses' knowledge in enteral feeding and tracheostomy care and to identify what challenges they had. And obviously from identifying those challenges, I obviously had hoped to make recommendations and try and improve them. When I did my literature review, what I found was that there was hardly any articles from the view of the nurse working in the community. There was quite a few of the side of the parents. And there was one article I can remember reading, and it was the parents' description of what they felt a perfect nurse would be. Let's be very frank, none of us are perfect nurses. We're all nurses doing the best job we can. So that was quite interesting to actually read some of those articles. Ethical approval was granted in 2017. Next slide, please. My population was 100 and it was a convenient sampling. Essentially, it was all nurses working in resilience at that time, and they all received a questionnaire in the post. They all got one email reminder, and there was a reminder as well that I would have given nurses maybe at staff meetings and things like that as well. I did get a response rate of 67%, which was fantastic. And when I sent out the questionnaires, I also requested with several a 10-day focus group. So I actually held 3 focus groups, and we had 13 people who attended those focus groups. The focus groups and the reasons, I suppose the themes and what we talked about in the focus groups were very much the free text questions that I had gotten from my questionnaires. And from that, I obviously had a load of recommendations, and most of them were implemented. And most of them have actually been compiled into my role as clinical practice specialist. Next slide, please. In terms of some of the things that I wanted to know of was obviously, in terms of the knowledge on tracheostomy care and enteral care, it was just some essential nursing care needs. And a lot of it was, when do you change a tracheostomy tube? How do you manage a blocked gastrostomy button? I also obviously wanted to know their geographic details, for those participating, how many years qualified, what was their highest attainment in terms of academia, and how long were they working in the community. And then the last questions were all those free text questions that I delved into further then in the focus groups. Next slide, please. And one of the biggest things I would say that I actually did in the focus groups was quite unusual, and there was very little literature about it, was something called concept mapping. So we've all done a mind map, and that's essentially what it is. But in research, it's called concept mapping. And it was about putting those themes that I had clumped together from my questionnaires. And it really just kept my focus groups focused on what we needed to discuss and those topics that I wanted more information on. Next slide, please. So some of the things then some of the comments that I got back, and the ones that I thought were, that I suppose I talk about more and that I thought were really interesting for me and my work to work on, where some of the things was, a few nurses, participant 3 said, I have no one to share my successes with, which was quite hard to hear, because we're all successful at varying things we do, whether it's, that you've run a 5K or you've done a half marathon or you've got your degree. Who do you share that with when you're a lone practitioner in the community and you're caring for a child in the family home? Your team is virtual. So how could we make that a little bit better for them? Participant 1 said she had no one to run things by. Participant 7 said, my concern was, who protects us? So that participant delved into it a little bit more and said, you know, from a child protection and welfare point of view, we're there to protect the child, to look after them if anything goes wrong, if anything happens. But who protects us? So that was really about that governance structure. Even though we knew in management we had it, obviously some of the nurses still didn't feel that clinical governance structure was fully there to support them. Participant 6 said we need to trust them. So we need to trust those parents and they need to trust us. It's a two-way thing. So that was about recognizing that trusting relationship that we build, how we can build it, how we can make it stronger. And for us in resilience, there were several ways that we have built on that over the years. We have always done shadow shifts. So what that means is that if a new nurse starts in a service, they get a set number of shadow shifts with a nurse who knows that child and young person and that service really, really well. So it gives them, the newer nurse, time to hone their confidence and competence, and it ensures that trusting relationship is already being built. The other thing I'd always advise nurses new in the community is, you might know a way of doing something and it might be the best way of doing it, you know, in comparison to evidence-based practice. It's what's current, it's the guidelines, it's what we should be doing. However, some of the children and the families we look after, they've been at home for 10, 12, 18 years with tracheostomies, with ventilators, with enteral nutritional devices. And the families have been doing it the same way as they were first taught all those years ago when their child or young person was discharged. What the family are doing is not wrong. It's probably just an older practice. So as long as it's safe, I would always advise nurses to do it the way the parents are doing it. And the best way to manage that is very simply ask the parents, will you show me how you want me to do it your way? It's a very small question, but it starts instilling that trusting relationship with the parents, that we recognize that they're the professional in their child's care straight away, that we want to do things their way. Participant 12 said, we do get invested in the families and their lives, but you can still maintain that professionalism. So something, again, I always tell new nurses in the community is, you can be friendly with the families, but we're not friends with them. We're not sitting in the pub on a Saturday night going out with them or having a meal with them. You can be friendly, but they don't need to know all the ins and outs of your life. You know, there is that boundary you still have to maintain. And as the professional in that family home, it is up to us to maintain that boundary. Okay. Participant 10 said, I think we just need to show up, you know, and to show the family that we care, to show them empathy for the situation they're in. I'm not too sure if many of you have read that Welcome to Holland by Pearl Kingsley. It was written in the 1980s by a mum of a child with Down syndrome. And she was asked to pen how she felt it was to be a parent of a child with what we would now say a child with complex healthcare needs. And she writes about how everyone is, you know, her and all of her friends are planning this big trip. They're all going to Italy. They've looked up the guidebooks. They know some handy phrases. Everyone's going. The day arrives and they all take their bags, but her plane takes her to Holland. Wasn't expected. She doesn't know the language. It's a slower pace of life. She doesn't want to be there, but that mother has to stay there. And she has to learn new languages, new phrases, new words, and meet new people. And they will always grieve that they never went to Italy. But if they don't stop and look around and see what's in Holland, they will miss all the beautiful things that is there. So we need to show the family empathy for the predicament they find themselves in. I don't think any of us can ever fully understand what it's like to have to, you know, to have to bring our child home. We have to allow up to 20, 40 strangers into our house every single week. It's incredibly, incredibly challenging. So we need to show empathy for the families that we work with. I think bridging the gap between us, and this is what participant 5 said, the advanced community care nurses, and between the tertiary centre and the family is needed. So we all need to work together. It doesn't matter essentially who's paying our wages, whether it is a provider, a public hospital, a private hospital, the community setting, a charity. We're all here as children's nurses to do the best we can for the children and the families we support. We all have the same aim, and that aim is to make sure these children are well looked after and at home with their family and friends. That's all we ever want for these. Next slide, please. In terms of the recommendations, then there obviously were several recommendations. And as I've said earlier, they have very much been incorporated into my role over time. So the biggest one really, I suppose, was the role of the clinical practice specialist. But there were a few other things that I just want to hone in on as well. So Schwartz rounds were one of the ones that came. Now, the recommendation itself wasn't Schwartz rounds, but if you remember in the last slide, a nurse said, you know, who cares for us? So from that, and with the Foundation of Care here in Ireland, our Director of Services organised Schwartz rounds to be delivered with our nursing teams here in Resilience. So we currently have, I think we run anything from 4 to 6 a year. We obviously had to move to Zoom during lockdown, but we do try and have them in person if we can. And we do them in several different areas around the country. I'm sure some of you know already about them. There's a theme, and you have talkers who will tell a story around that theme that they've met throughout their career. And what we would find at some of them, and I've spoken at one of them, is that it brought up things that I thought I had dealt with from a long time ago was my story, but I thought I had dealt with some of those issues and I hadn't. But being able to talk in that confidential forum was really, really good. And it definitely shows our nurses that we are looking after them, you know, so that was definitely one of the better things. The other thing we've done is that greater emphasis on team. So it's highlighting to those nurses and to all of our nursing colleagues in the community is that we get that you're a lone worker, but we're trying to improve things now for them, such as team bonding days, team building days. It's obviously coming into Christmas. So I know the local team here to me in Cork are actually meeting at one of the food markets here for Christmas, and they'll have their team meeting there and they'll catch up and do all their lovely bits and pieces, which is obviously what we want. Next slide, please. So in terms of my role then as clinical practice specialist, and as I said, everything else has probably rolled nicely into this. So my role as clinical practice specialist was one of the biggest recommendations. So initially, myself and the managing director, Laura, we sat down and we had a conversation about that framework and how we as a provider could better support children and their families living at home, but also support the nursing teams around us. The role did take about 9 months to come to fruition, and both myself and Laura, and Olivia was my direct line manager at the time, had a say in what we thought could be included. We also looked at other jurisdictions as well to see if they had similar roles, and we looked up a few job descriptions to see what could be realistically achieved in that one role. And from that, and with a bit of time, because I suppose the other reality was I was a nurse manager managing one of the 4 provinces in Ireland, and I had to hand over all of my services and all of the children and young people I was looking after. So they actually had to backfill me out, and that just took a little bit of time, which was great in terms of that I could support the newer managers then transition, and they got more time to transition into their role with my support. And then we really had that time then to actually solidify what we wanted that role to be. In terms of my role, it has 4 main components. So teaching and training was one of the biggest components. It's now gotten lesser over time. So we know as nurses, and especially I suppose in Ireland, and I'm assuming in probably every other country, you all have a similar thing. We have what's known as the Nurses and Midwives Act. It's from 2011. And even though Part 12 is not enacted yet, it would recommend nurses get between 21 and 24 CEUs every year. And that helps us maintain our clinical competence and confidence as professionals. And we do know it as well that we all need to update and upskill regularly. I suppose I strive in resilience to ensure that the nurses working with me have access to all the courses that I have gotten approved. We currently have 40 sessions approved by the Nursing and Midwifery Board of Ireland, and they vary from 0.5 continuing education units to 35 units, and each unit represents approximately an hour of studying. Some of them are pre-recorded sessions, such as maybe about the diagnosis and management of a person with spina bifida, or maybe about Dravet syndrome, to the bigger one, which is the 35 credit module. And that is essentially specifically aimed at overseas nurses who have done their undergraduate outside of Ireland and want to come and work in the community setting. So it's about helping them get through their entry examination to be registered here in Ireland, and also about that change in the healthcare system, and obviously then the clinical skills they need to actually work in the community with children with complex healthcare needs. I obviously work a lot with our nursing board in terms of getting things approved, and how quickly I need to get things approved. Have I the applications filled out right? All of those things fit into that teaching and training bit. I do still do the occasional shadow shift for very, very complex children as well, if needed. And I do work very closely with the universities, and we would have organised student placements. So we are linked with 2 universities here in Ireland for students to come out on placement with us. In terms of the nurse specialist part of my role, I support the nurse managers on the very complex cases, and we do joint visits together. And all of that is really about improving that service provision and improving things we can for the children and young people. So probably one of the barriers we would see here in Ireland for some of these children is getting them into mainstream education. So whether it's their primary school, post-primary, or college or university, that we are still hitting the occasional barrier. And how can we get those children into the right education that they're perfectly entitled to access? So we obviously do quite a lot of work with that, and we obviously have risk assessments, because yes, they might open up their door and say this child can come, but do they actually have the facilities, and is it a safe place for this child to attend in terms of the nursing needs that may be required during school? The other thing in joint visits, and I'm just going to give you a brief example of one young person I've been working with for a little while quite closely. It's a young man, and he's been at home for approximately 15 years with a tracheostomy and a ventilator. He is paralysed from the neck down, and he has full care needs. He is doing incredibly well. He's only had, I think maybe 3 admissions back in hospital in 15 years, which is minimal when you think about it. But obviously over 15 years, equipment and consumables have hugely changed over the years. And recently I went and I showed him a newer enteral nutritional device, and we talked about the pros and cons of it. And the reason I wanted to talk to him about it was that he was having issues with the one he was currently using. And like a lot of things in a lot of countries all over the world, if something isn't broke, why are we going to fix it? So it wasn't broken, so there probably wasn't really a need to fix it. However, I knew there was a better product for this young man. So went and had a chat. I had a copy of one for him to see, so he could see it. He knew what it exactly was about. And he decided, after all the pros and cons, that he wanted to meet the nurse advisor with the company of the new enteral nutritional device, and he wanted to actually trial it. So I organised all of that, and I was there with the nurse advisor, and between us, we put in the new enteral nutritional device, and it has worked incredibly, incredibly well. So that's, that's part of that specialist role. It's about improving those things. In terms of practice development, the practice development is probably the more admin side of my role. And look, let's be honest, as nurses, not many of us relish the admin side of my role. And this has definitely hugely evolved over the last couple of years. So a few things. I am the chair of the Quality and Safety Committee. So I chair a meeting every 2 months and we discuss all the incidents, accidents, near misses that happen in advanced community care in resilience. So what happens, anything that happens with children with complex healthcare needs that we support. Is there a pattern? Is there a learning? Can we stop it happening again? What actually has happened? And there can be a range of things, and we'll discuss them and we'll talk about them. Something that comes up regularly and there's nothing we can do, and it's because they're children. They'll fall, they'll hit a nose, they'll bump a head, and that's normal things. And sometimes I think that is forgotten, that children with complex healthcare needs are normal children. They just need a little bit of extra help and support. So they are going to have bumped heads, bumped noses, bloody noses, broken arms and legs and everything else, but it still does need to be identified as an accident and an incident, basically, or a near miss. One of the things we've recently done in the Quality and Safety Committee was we actually reviewed the document, The Life and Death of Elizabeth Dixon in the UK. She sadly died in 2001, but her death was only investigated in 2019. And there was a number of recommendations by Dr. Bill Kirkup, who actually led this team. There were 12 recommendations in total. And I'm happy to say only 10 of them pertain to us in community. And we actually already had, all of them really implemented. We just tightened them up is what I would say. So we're probably slightly ahead of the curve in that respect. I would have also developed a suite of clinical guidelines. So this is all basically the blueprint of what we should be doing in the family home, whether it's looking after a child with a tracheostomy, looking after a child with a post-pyloric device, looking after a child with seizures. All of those things are within those suite of policies. There's always going to be new ones coming up, but kind of they're our general backbone of it. And in terms of where do I get the information on my clinical policies, we obviously have our tertiary centres here in Ireland. So Child Health Ireland, I very much look at, and I very much look at the Royal Children's Hospital in Melbourne, who obviously is a leading child health hospital. I would also look at Great Ormond Street as well in the UK, and I'd also look at the Children's Hospital in Philadelphia for quite a lot. I've also organised a number of annual conferences. So this went back again to one of the recommendations. We have done a palliative care conference, and this year we obviously had to take a break with COVID, like most people did, and this year was our first one back. And we actually, I suppose our subject heading was about caring for people with spinal injuries in the community, and we had an absolutely great lineup, and it was held in October. So I have a roadmap of what I want the next few years to be as well. The final part of my role is networking. So I suppose, what does networking mean? So it's essentially doing things like this with Sigma. It's about talking about me, talking about my role, and talking about the job we do in resilience. It's about going to conferences and training days. It's about doing some research projects, getting poster presentations, getting abstracts, maybe doing podium slots at conferences. I've presented my masters at several national and international conferences. It's about going into the universities and talking to the undergraduate students to know that caring for children with complex healthcare needs is an absolute pathway that you can take if that is what you want. There is one postgraduate course here in the Republic of Ireland to support nurses to do this course after qualification. And I know there are several in other jurisdictions as well. Next slide, please. My role is now 4 years old, and I've absolutely seen a massive shift in it. In my first and second year, I spent a large amount of time getting training sorted, getting it approved, doing training needs analysis. What did the nurses need training on? What did the client's nursing needs consist of? What could I actually teach internally? What I felt I was an expert in? What I needed to actually organise externally as well. What I could get approved as well. What I would say is that the training element to my role has definitely seen an improvement in retention. And because we're now retaining nurses, those training needs have changed as well, because they're now refreshers instead of full-on training days that I can now facilitate. What I would say is, even though my role has those 4 strands on it, it is absolutely changed in terms of that it's continued to evolve and broaden. So yes, it has those 4 strands, but each strand takes a different precedence depending on what's going on. So over time, as I said, the training and education one was definitely the busiest one initially. I'm actually now finding the quality and safety one for the last kind of 3 odd months has been the busiest. Going into January time, I actually know that the networking one is often the busiest, because that's when the community module is taught in the universities. And that's when several of the universities will link in with me and ask me to come and visit and talk to their students. What I would say is that I'm finding as nurses are more confident and more competent in their skills, my role is changing. And as I said, the significance in the busier periods are changing slightly. But I think as advances in medicine continues to flow and ebb, my role will also flow and ebb as needed. In terms of my advice for you, and I think it probably says it here in this slide, which was something that was said at our conference by an amazing speaker called Jack Kavanagh. He said, small keys can open big doors. So my role was absolutely a bespoke role. And what I suppose I found was that my master's only had 100 participants. So that's a really tiny population and sample size in research. But there was such good knowledge and dearth. And I was very fortunate that my managers listened and could see the gap that we highlighted, that this role was needed. So I suppose those small keys, those small little things from the masters that came about absolutely opened up a very big door for me. It opened up the role that I currently have and that I continue to do every day. And that's it. Next slide. Thank you.
Wow, this has truly been lovely. I've been sitting over here taking notes myself, Cora, so I want to thank you for sharing all of this. We're going to dive into some questions. We do have a question here. Did the pandemic highlight any additional health disparities in this complicated population?
I think what the pandemic highlighted for some of the children and the families we support was that a lot of it was disinformation and lack of knowledge. So some of the families straight away shut their front doors. They didn't want us, they didn't want help. But after a little while, when we learned more about COVID, they were more receptive to getting help. We probably didn't see the health disparities that other countries would have had, such as I know in the UK, especially in London, there was a very high death rate of Black African Americans. We didn't see that in Ireland as such at all. And especially not in our children. Our children, when I say they were wrapped in cotton wool and cocooned to an inch of their life, some of them were not seen sight nor sound of for a couple of years. You know, very few of our children and their families actually got COVID, thankfully, touch wood.
Interesting. You know, I think it's the comparison country to country and what that looks like. You know, I think a lot of times the Americans, we don't see that, right? We don't see the global implications. And I think that is what we just see from our narrow lens. And I think this quote that you said, small keys can open big doors, by Jack Kavanagh, is just a beautiful quote. And so what would you recommend for somebody that knows the potential is there, but they either have real barriers to advance practice or perceived barriers, and they just don't know where to start? What would be your recommendation?
I think knowing your research. And when I say by know your research, identify that gap that it's needed. So if you can have the backing of that research, of knowing that it's there and what the positive outcome of that role will be. So I just said to you there about that young man. So that was a really positive outcome for him. So it's about knowing that, it's about having the positives. If you can actually financially, if you know the financial implications of your post, which is probably something I didn't touch on, but we were obviously within resilience, we were obviously exporting all of our training. So all of our nurses had to be trained externally. I was doing a little bit ad hocly as a nurse manager, but I couldn't facilitate everything, was the reality of it. So there was a huge expenditure in training. So we knew now they weren't spending as much as my wages were, but we knew in time that it would probably, save them money going forward. Because training nurses is expensive, let's be honest. So I think if you can back it up by research, the financial implications of it, and highlight the gap and the good work it will do, they're all positive things to get a new role established.
Yes, I love that. And I think, return on investment. So it might be a financial stretch right now, but in the long run, it definitely is going to be worth it. We have a question here from a participant. At first, was your role readily accepted by nurses in the community setting? If not, how did you deal with it?
So it was readily accepted by my peers. And I think part of the reason it was readily accepted was because I'd been around for 6 years prior to this role. So they knew I had the expertise, they knew I had the knowledge, and they knew I knew basically what I was on about. So I think in that respect, I was accepted by most of them. It was actually probably by my acute colleagues that I probably had the hardest time getting them to recognize that you can be an expert and not be based in the community or not be based in the hospital. So it's probably that real mind shift as an entire generational thing, that you don't have to be a nurse to work in the hospital. You can work in the community and have that expertise outside it. So it's taken a bit of time, and a lot of it is talking to them, meeting with them, meeting at conferences with them seeing my research, them listening when I'm, doing a podium presentation on something. So it's just almost, ticking away slowly but surely at them for them to recognize me in the community. But I think it's probably there now, to be fair.
Yeah, and I think just developing trust, and I think also developing and showing your skill set and all of the great things that you've done for the community. It sounds like you're really, advancing care, which is so wonderful. Now, do you have, has your new role demonstrated retention, reduction, and turnover of nursing staff?
So it actually has hugely, we've seen it. And I think I've even, I don't have the exact figures now, to be honest, but I do know we have an incredibly low turnover in comparison to previous years. I'm with Resilience now over 8 years, and we've definitely seen a reduction in retention. We've seen an improvement in retention. I think how I've seen it is that I keep seeing the same nurses for refreshers every 2 and 3 years, which is actually really nice. That number one, they're coming back for refreshers, but number two, that they're still with us. So yeah, I definitely see that there has been a big improvement on retention.
And how long did it take you to feel comfortable in your new position?
Um, Oh God, I don't know some days if I'm all that comfortable. I think it depends on the strand I'm in. So for example, the Quality and Safety Committee only came into being just over a year ago. And that took me a while to establish, and being comfortable to actually chair a group of my peers who are experts in their own right as well. So that was a new learning curve for me. So there are still things I'm not 100% comfortable with, but I would say overall, probably in the probably 2 years for it to be bedded in well and for it to be seen as the role it is.
Wonderful. And the next question we have from a participant is, how do you see it evolving more in the future?
I think how I would like to see the role evolve is I think there's room for more of the roles. I'm the only one, and I do only work with one provider. There are 4 other providers on the framework. You know, they need to be providing an equal to service than we're providing as well. We're all here for the same thing for these children. I also think the use of learning management systems would reach more nurses for training and education, which is what most nurses want. I'd also like to see, maybe have courses that are affiliated with universities as well, because at the moment they're just accredited with the nursing board. I'd love to see them affiliated as well with some universities. I'd love us to have better links with some universities, maybe for more student nurses. Oh goodness, I feel I could go on and on. I'd love to do more research on kids with tracheostomies to kind of smooth their pathway home as well. And just, improve services overall, really.
I think that's beautiful. So many great ideas. And I think I would say we're confident that you can definitely lead the way in that work. Cora, before we wrap up today, any parting words you want to share with our participants?
I suppose, just to kind of recap, I really hope I've given you guys some bit of food for thought, really, from my career journey into where ye currently are now, and maybe just think outside the box, and what isn't a role could always potentially be a role if you get the right information at the right time to the right people. And kind of, as Jack Kavanagh said, really, I think small keys can open very big doors. And thank you all for listening.
Wonderful. We want to thank you so much for sharing all of this great information. Sigma is grateful that you took time to share with our audience, and we definitely look forward to hearing more from you in the future, Cora. We hope you enjoyed this webinar. As a reminder, 1 week from today, you will be emailed a link to the evaluation for you to obtain your Nursing Continuing Professional Development Certificate. Be sure to check out Sigma's upcoming webinars and resources to support you and your colleagues at sigmanursing.org. Also, previously recorded webinars are freely available on the Sigma repository. Thank you so much for joining us today, and have a wonderful day.
Thank you. Bye.